you may be just joining us for the first time, and it's our pleasure to have you on board and hopefully offer you some additional information to expand your knowledge and comfort with incorporating antibiogram data. Before I get started and introduce our speaker, I'm going to remind people of a few housekeeping items. Please note that everyone's phone will be muted when you enter the site. And that's just to minimize any potential for background noise. When it comes to the question and answer period towards the end, then we'll be able to have the phone lines unmuted. In the interim, if you want to send questions or formulate questions, you can use the chat box at the bottom of your screen and send the speaker any information or comments that you would like to share. We are very happy to share that this morning, participants will be able to receive 1 full hour session of continuing education credit, either as CPE or CNE. The nursing credit also came through today. No partial credit can be awarded, and an online CE evaluation will be emailed to you following conclusion of the program this morning. You must complete the evaluation, and we'll share that information again towards the end. For the nursing credits, there was a separate announcement when you registered to remind you that to get CE, you must sign in at the beginning of the activity, attend the entire session, and then complete the evaluation form. You will receive your CE certificate from the University of Maryland School of Nursing about 2 weeks following the program. This session will be recorded and will be available on the Lamy Center's Antimicrobial Stewardship website shortly after our program today. So without further ado, it is my pleasure to introduce our speaker. Dr. Kimberly Claeys is a board-certified pharmacotherapist who is in the practice area of infectious disease and antimicrobial stewardship here at the University of Maryland, and serves and works at the University of Maryland Medical Center. I'm going to turn the program over at this point to Dr. Claeys, and we will hear her presentation of how to measure the effectiveness of incorporating antibiogram data at your facility. Kim?
Yep, thank you. Thank you, Barbara. So again, today we're going to look at incorporating antibiogram data at your facility and how to measure that. These are just my conflicts of interest. I've served on advisory boards for Malenta and Abreva Therapeutics, and I've been a speaker for Luminex, maker of Verigene. The objectives for today, we're going to identify properties of antibiograms that can be incorporated into facilities, policies, and procedures. We're going to look at key concepts for optimizing use of local susceptibility data at your practice site. And we're going to determine process and outcome metrics to evaluate incorporating that data at your practice site. Based on those objectives, the lectures outlined as below, we're going to do a very, very brief review of antibiograms. We're going to recap antibiogram challenges in long-term care, something we talked about at the summit in September. We're going to look at ways to integrate that antibiogram information into your facility. And then we're going to look at metrics to measure the success of that integration. Putting it all together, there's going to be an example interspersed throughout the slides that will help kind of tie everything together. So back in September, we had the Antimicrobial Stewardship in Long-Term Care Summit, and Dr. Christy Johnson, our Director of Clinical Microbiology at University of Maryland Medical Center, provided an in-depth review of what clinical microbiology, including susceptibility testing. So I'm not going to go into this in depth. This is just a slide meant to be primer and background. But for basic brief background, your clinical microbiology lab completes susceptibility testing on individual samples. You get a sample from an individual patient, whether it's urine, blood, or sputum. You send it to a microbiology lab, and the goal is for organism identification. And then if there is an organism causing infection, it's susceptibility to specific antimicrobial agents. We look at susceptibilities in terms of minimum inhibitory concentrations, or MICs, and those MICs get referenced against clinical breakpoints for certain microorganism drug combinations. And we determine whether or not that microorganism is susceptible, intermediate, or resistant to that antimicrobial. So for instance, the table on this slide refers to an individual sample from an individual. Perhaps it was a blood sample, organism identified was Staph aureus, and you can see the susceptibility report and it being basically pan-sensitive to all the antibiotics it was tested against. So that's a very brief primer on susceptibility testing, but we've gone through that before. Antibiograms are sometimes called cumulative susceptibility tests or cumulative susceptibility reports. They're reports that are usually generated by a clinical microbiology lab or can be generated by another person, such as a person in infection prevention. They contain bacterial isolates from patients at your facility or local facilities, and they help you to look at the percent of those isolates that are susceptible to a given agent. So you're still looking at your microorganism drug combinations, just instead of at the individual level, at a higher level, whether it's a facility or a group of facilities. The goal is to provide empiric antibiotic choices based on local susceptibility data, so help your providers make more educated choices in terms of empiric antibiotics, and it can also be used to help monitor trends in resistance at your facility. So we'll go over some of these in a bit more detail throughout this lecture, or presentation, sorry, but next webinar, Dr. Johnson will go in more detail about what the actual nuts and bolts of the antibiogram are. So since Dr. Johnson's going to cover this in more detail next month, I just want to give a very brief background. A lot of things go into making an antibiogram. The Clinical Laboratory Standards Institute has guidelines on how to properly develop antibiograms. Usually you take one sample per patient, the first sample in a given time period, and it should be a sample meant for diagnosis and treatment as opposed to, say, a surveillance sample. You make sure you document the patient, the source, you look at the date. Antibiograms are usually updated yearly, so we call them annual antibiograms, but they can be different time periods. But the main idea is that you need to periodically update your antibiograms. And then you look at your organisms and the antibiotic susceptibility profiles for those organisms. By the CLSI guidelines, you should ideally have at least 30 organisms of the same type in order to make generalizations about antibiotic susceptibility. So that's a very brief kind of what goes into an antibiogram. Again, Dr. Johnson will speak more of this in March in terms of the actual nitty-gritty of it. With all that stuff going into it, this is what it ends up looking like on the other end. Basically, this is a gram-negative antibiogram. We can see here at the top, we've got antibiotics that were tested. So we have our aminoglycosides, our beta-lactams, cephalosporins, quinolones, and other agents. We see the name of the organisms that were tested, including Acinetobacter, Citrobacter, E. coli, cleve, and so on. N here refers to the number of organisms that were collected during that time period. So I mentioned antibiograms may be updated annually, so that means that there were 444 Enterobacter that were collected to be added to this antibiogram. And these, when you cross between the antibiotic and the microorganism, that is the percent of those microorganisms in that species that are susceptible to that antibiotic. So for instance, Enterobacter species, 96% of them were susceptible to gentamicin. And then the little grayed out areas are those that are not tested, whether it's due to intrinsic resistance, such as the ones I'm highlighting here for Pseudomonas and ceftriaxone and cefazolin, or it could be what your microbiology lab decides to test in terms of susceptibility panels, or it could just be whether or not you decide not to include a certain antibiotic because it's not on formulary. But the grayed out areas basically mean not tested. So that's what the antibiogram ends up looking like for the end user. So why are antibiograms important? Well, we suspect infection. We collect a sample, whether it's a blood culture, sputum, urine, etc. It usually takes days between sample collection and final organism identification, and then susceptibilities. So between that time, ideally the provider will start empiric therapy. And then once we get that targeted information, we can actually then tailor our antibiotics. Since it often takes several days to get organism identification and final susceptibility, the antibiogram will help the provider make a more informed decision on which antibiotics will likely work, given a certain infection type and most common cause of organism. So, for instance, if a patient has a urinary tract infection, they can look at, well, what's most likely to cause a urinary tract infection, say E. coli, look at their antibiogram, and make an educated recommendation about what antibiotic is most likely to cover it based on your local susceptibility patterns. Then once, in 24, 48, 72 hours later, once you get identifications and susceptibilities, then you can tailor antibiotics. But until then, the antibiogram helps the providers make that empiric choice. Additionally, antibiograms are a great tool for monitoring trends in resistance. They help with the CDC core elements for antimicrobial stewardship in long-term care, in particular looking at tracking and reporting. So they'll help provide feedback on resistance patterns in your facility, and we'll talk more about that throughout the presentation as well. So I've kind of briefly gone over what an antibiogram is and how it can be used, but before we jump into integrating them at your site, I just want to remind everyone about some of the limitations of antibiograms, and then we're going to talk a little bit about challenges of the antibiograms. So first thing, antibiograms are not generalizable. If you take our University of Maryland Medical Center antibiogram from 2018 and try to apply it to your patients, it will likely not be a very good fit. You will likely find that your resistance patterns do not match ours because they are not generalizable. We don't see the same types of patients. Also, they only report phenotypic susceptibility. You don't get MIC data. You don't get any data about intrinsic resistance. And very importantly, they don't take into account individual patient factors. So patients' factors such as if a patient has a previous history of drug resistance, such as a prior extended spectrum beta-lactamase producing a gram-negative, it doesn't take into account if they've got drug-resistant organisms on another body site, whether it's from another diagnostic or from a surveillance culture. It doesn't look at their past antibiotic exposure, comorbid conditions, or level of acuity. So the antibiograms are meant to help inform our decisions, but they should never supersede individual patient information and clinical judgment. And before I go into the actual integration, I want to just recap some of the challenges of antibiograms in long-term care. We talked about this at the summit in September, so these slides may look slightly familiar, but I want to reiterate them. Long-term care facilities do face unique challenges when developing antibiograms. Facilities often have small numbers of patients to draw samples from, and then they have an even more limited number of diagnostic isolates. So your ability to actually create an antibiogram where you have those minimum of 30 isolates per organism becomes difficult. And there's also technical difficulties. You might be working with multiple clinical microbiology laboratories, and that can make it technically difficult to combine that information into one usable report. They might be testing different microorganism drug combinations, and you might get that information presented to you in different ways, and trying to collect all that information together can be technically challenging. And that's made all the more difficult if you do not have electronic medical records. So these are some of the challenges that long-term care facilities face. So it's easy for me in the acute care side to say, oh, here's our antibiogram and here's how to integrate it. But these are some of the challenges that we are aware of for long-term care. Our colleagues in Rhode Island did actually look at some of these challenges and look at potential approaches to dealing with those challenges. They have this table here, and this is another table that I presented at the summit that shows the approach with potential advantages and disadvantages. I'm going to go through these quickly. The first one, if you have a limited number of patients and diagnostic samples, you can extend your antibiogram data beyond 1 year. This is a CLSI endorsed method to overcome limited organism sample sizes, and it's technically simple and easy to do. You have a pro and con. Resistance patterns may change from year to year, so you might not catch that, but on the flip side, you might be able to catch more long-term changes in resistance patterns. Another approach would be to create a regional antibiogram. So this might be one of the viable options. It can be technically challenging though. It's helpful if residents access facilities throughout the region. You've got a very geographically close and similar patient population. You can combine information, but if you're using multiple different laboratories and between the facilities, that can again be technically challenging, like I mentioned before. They do mention using antibiograms from nearby hospitals. The one thing I did say, the limitation of the antibiogram is that it's not generalizable, and that tends to be true. We covered at the summit some data showing that resistance patterns in long-term care patients were not similar to their geographically close acute care counterparts. So using an antibiogram from a nearby hospital, they may not have similar antimicrobial susceptibilities to that hospital population, so that might limit your desire to use a nearby antibiogram. And the last approach they talked about was collapsed antibiograms to help guide infection-specific antibiotic choices. Collapsed antibiograms mean collapsing or grouping similar organisms and specimen sites. So for instance, you might have a urinary antibiogram where you collapse certain things like E. coli, Klebsiella, and Proteus all together into one to increase that number of organisms you can draw from. They can help guide certain types of treatment, but they do have limitation where you're starting to make it less specific for those organisms, so you might miss some certain intrinsic resistance of some of the bacteria. So that's some of the challenges that we discussed and some of the ways to overcome them. But once you have overcome them and you have a validated antibiogram, how do you go about actually incorporating that information at your facility? So once you have a validated antibiogram, you first need to have policies and procedures in place for how to use that antibiogram and how to maintain that antibiogram. You need education of nursing and prescribers to make them aware of what the antibiogram is, how do you read it, where is it available, and then widely disseminate that antibiogram as much as possible. So we'll go into these in a bit more detail. So nursing and provider education is key. They need to know kind of what we talked about in the first part of this presentation. What is an antibiogram? Why is it important? How do I read it? They also need to be aware of where it's available. So if possible, making it available through institutional web pages and providing handout pocket cards of the most recent antibiogram. When you are updating the antibiogram, not only just sending out a quick email, but also maybe going and providing in-services for re-education as an opportunity to make either people who were not using the antibiogram the way that we optimally would hope they would, or new providers to become aware of the antibiogram that's available. So making sure that it's on the minds of providers who are prescribing those antibiotics that they do have that information available to them and making that information available to them in the easiest way possible. When doing things like developing policies, procedures, and these education materials or communications that I'm mentioning, you don't have to reinvent the wheel. One of the places that does have a lot of pre-made materials ready is the AHRQ antimicrobial stewardship toolkit for nursing homes. In particular, AHRQ's Toolkit 3 is the implementation phase. It provides sample policies and procedures, education materials, draft emails and communications. And then once we talk about looking at metrics, it also provides some tools for helping you monitor the use of the antibiograms, looking at antibiotic use and tracking forms and antibiogram feedback surveys. So there's no need to completely reinvent the wheel with these things, as there are resources available. And this is an easy to find AHRQ website, but it's also posted at the Lamy Center's resource page. So once you have that antibiogram at your site and you want to incorporate it, you can look at also not just looking at policies and procedures for how to have an antibiogram, but also how can you incorporate them to other clinical pathways, which we'll talk more about in detail with the upcoming slides. Other things you can do, you can consider changing antibiotic recommendations in order sets or clinical decision support services. So if you have a pre-made order set that has a certain list of antibiotics in it, you can review those antibiotic choices against your antibiogram. You can also make decisions regarding your facility's formulary. If you find, based on your antibiogram, that your resistance is unacceptably high to a certain agent, you might consider removing it from formulary. Outcome metrics we'll talk about more in detail in the upcoming slides, but one of the most important outcome metrics the antibiogram helps you with is looking at trends in resistance at your facility. And then also it's important to frequently update your data in your antibiogram as much as humanly possible. We talked about annually, but then also might having to extend that time period based on the availability of a sufficient sample size at your site. So whenever you update that data, hopefully it is regularly, and then you can provide more education and service as you go to make sure people are aware that's been updated. This is an example. We're going to use the same example throughout the rest of the presentation, but basically this example is you have an antibiogram for gram-negative microorganisms with data that's been collected from over the last year, and it's been validated for your facility. This is now available to your providers. You happen to also be working on developing a new treatment pathway for the management of urinary tract infections at your facility. So you want to know, how can I use our antibiogram data to help guide how I make this pathway? So we'll come back to the antibiogram on this page. We're not going to spend too much time looking at it right now. This is also something we talked about at the summit. This is just a basic example of a pathway that you might develop based on national guidelines from the IDSA on how to treat urinary tract infections. Dr. Lika spoke in September about proper diagnosis and management of UTIs, and again, she'll speak again in more detail in one of the future webinars about limiting unnecessary testing and treatment. For now, we're going to assume that patients were tested appropriately and that treatment is appropriate. So now that we assume that some form of antibiotic treatment is appropriate, how do we make decisions about which treatments that are recommended are the most appropriate? So we're going to look at guiding empiric therapy, and we're going to look at our national guidelines and compare those national recommendations to our antibiogram. And it might change the recommendations we make for our facility based on the antibiogram. So on this slide, there's a lot going on, but focus on just the UTI treatments for uncomplicated, complicated pyelo. We have nitrofurantoin, cephalexin, amoxicillin clavulanic acid, TMPSMX, ceftriaxone. And then with pyelo, we have options such as fluoroquinolones as well. So those are the main treatment options for UTIs, right, according to national guidelines. We know that UTIs are most commonly caused by E. coli, so it's plausible that you would want to evaluate your local susceptibility information for E. coli when trying to customize your treatment recommendations compared to just using national guidelines. So I've highlighted E. coli and the guideline recommended antibiotics using amsulbactam as a surrogate for amoxicillin clavulanic acid. We see that for a lot of our guideline recommended antibiotics for UTIs, our susceptibilities are not great, below 70% for amsulbactam, around 70% for cefazolin. The fluoroquinolones are close to 60%, and then TMPSMX is only at 65%, so we're not having a great susceptibility profile for those agents. So based on the fact that our amsulbactam, TMPSMX, and quinolones have high rates of resistance at our facility, with susceptibility rates all around or less than 70%, we decide that we're not going to include them in our empiric antibiotic coverage recommendations in our UTI treatment pathway. So the goal of this is that we're going to improve empiric antibiotic use by having more patients on therapy that will cover the organisms subsequently isolated from the urine cultures. We will decrease use of potentially TMPSMX and fluoroquinolones when we have already high resistance rates, so we don't have to wait until the culture comes back to know that we were not treating them appropriately. So that was an example of incorporating the antibiogram information at your site using a UTI treatment pathway. But after we've incorporated that, how do we know if it's actually working? So after implementation, we want to measure the success, and we do that through a series of both process and outcomes metrics. So process metrics, for lack of a better term, they look at steps in a process that are anticipated to lead to a certain outcome. Process metrics often act as surrogates for the actual outcome, but they can also be really valuable because they assist in improving system functions and looking at root causes of inefficiency in the way you do things. On the other hand, outcome metrics are more high-level clinical metrics that are related to actual patient care outcomes. And basically, you want to use a combination of these because a combination of both process and outcome metrics are frequently required to be measured by certain regulatory agencies. So we're going to talk more about process and outcome metrics throughout the rest of the talk and how you can use those to measure the success of how you've integrated the antibiogram information. Measuring success, we're looking at least most difficult. As a general rule of thumb, process metrics tend to be easier to collect than outcome metrics. The easiest process metric to collect is cost, in particular antimicrobial acquisition cost or drug cost. Although it's easy to measure, these costs have been shown to be poorly aligned with antimicrobial use. And importantly, to consider the antimicrobial cost itself doesn't actually reflect appropriateness or effectiveness. So although cost is easy to collect, it's associated with a lot of limitations in terms of measuring the success of your program. And then process and outcomes, we'll talk about more of those in detail. The most difficult outcome metric to measure and track is the development of resistance. This tends to take a lot of time, and it is a rate outcome that needs a lot of patients and organisms to truly see a difference. So an additional consideration with that is that antibiotic resistant trends can be confounded by factors outside of your facility's control. So that makes it the most difficult outcome metric to actually measure. So the CDC's guidebook for antimicrobial stewardship in long-term care does give some examples of process and outcome metrics that your facility can look at. Looking at process metrics, they recommend potentially reviewing medical records for any new antibiotic orders. Looking at adherence to antibiotic prescribing policies, so just a simple audit of how many patients are on antibiotic for, say, a UTI, what proportion of those are adherent to your prescribing policies. If you have active antimicrobial stewardship interventions at your facility, looking at the proportion of those that are actually accepted. And then also looking at duration of antibiotic courses. Are they appropriate in the duration, or are they inappropriately long or inappropriately short? Most likely inappropriately long, right? But looking at those durations of antibiotic courses. Those are all examples of process metrics. Outcomes that are important to look at, monitoring institutional rates of C. difficile infection. That's an important one. And then also you can consider looking at recording the incidence of antibiotic-related adverse drug events. The most common process metric is antibiotic consumption. So how do we measure antibiotic consumption? Well, there's a lot of different ways. This is a table that looks at various different metrics that can be used to look at antibiotic consumption that have been used in long-term care. We're not going to go into a ton of detail on this slide, but I did want to just kind of point out some of these metrics. On the left here, we've got the metric name, the definition, and then we've got some advantages and disadvantages. So for instance, you can look at a simple incidence, the number of antibiotic courses started per 1,000 resident care days. You can look at an incidence and see whether or not the incidence increased or decreased after you made a change in your recommendations. Cons, it doesn't measure duration, and it does require resident level data. A common one is antibiotic utilization ratio. You look at the ratio of total antibiotic days to total resident care days. It's just one divided by the other. It's a common metric used in studies, and it's used by things like the CDC and HSN. Again, it doesn't require duration, but does require resident level data, so it is a bit more technically challenging. As mentioned, costs tend to be easier to get. You can look at cost per antibiotic day, as well as cost per resident care day, but usually cost data, again, doesn't always actually account for antibiotic use or appropriateness. So there's some limitations with cost data. By far the most common antibiotic consumption metric you see used and reported is DOTs. So on this slide, we've got DOTs, which is days of therapy, DDDs, defined daily doses, and then the SAAR, which is our standardized antibiotic administration ratio, which is a newer metric. But the most common one you'll see used is days of therapy, and that's the days patients received at least one dose of antimicrobial, standardized to your patient census, and it's usually measured in terms of days of therapy per 1,000 patients or resident days. Because you standardize it to your patient census, it allows you to do intra-facility benchmarking, or you can actually benchmark between facilities. Similar to the metrics I talked about before, it does require patient-level data, so that can be technically challenging. But it is endorsed by CDC and NHSN's antibiotic utilization and resistance module. So that's the one we're going to talk about for today. The DDDs and SAAR is here for your reference, but we're not really going to talk about them beyond now. We're going to focus on days of therapy, or DOTs. So DOTs, antibiotic days of therapy, help monitor use over time. What's an antibiotic day? Well, it's each calendar day that the resident receives the antibiotic, at least one dose of the antibiotic, right? Antibiotic DOTs are the sum of all the antibiotics for all the residents in a given time period. So what's challenging about this is you have to consider each calendar day they received at least one dose. So if they received 7 days of cephalexin, that's 7 DOTs, but you have to assume that that was given over 7 days of a full course. Even though cephalexin can be given multiple times per day, if they even received one dose in a given calendar day, that counts towards 1 DOT. What if your patient's receiving both azithromycin and ceftriaxone, say for community-acquired pneumonia? Well, they received a 5-day course, that's 10 DOTs, because remember, each antibiotic has to count as its own. So if they receive 2 different antibiotics on the same day, that counts as 2 DOTs. As mentioned, DOTs are typically standardized to patient or resident census, and then to make it a usable or more feasible rate, you do DOTs per 1,000 patient or resident days. You can also simply look at your total antibiotic consumption over a given time period, such as a month, and divide that by your resident days to look at your antibiotic utilization ratio. There are 2 ways of looking at the same thing. One might end up being more intuitive to you than another. Usually the one that ends up being reported in literature is the days of therapy per 1,000 patient or resident days. So I said that this is going to be the sum of all antibiotics for all residents. You can also look at DOTs for a certain class of antibiotics or a certain antibiotic itself. You don't have to just look at all antibiotics. You might do a spot check on just one. An example of that would be looking at our example going back to the UTI treatment pathway. We eliminated certain antibiotics from that pathway. We would suspect to see a decrease in their use. One way to monitor that decrease in use would be to look at days of therapy. So thinking about process metrics related to integrating that antibiogram information, some of the process metrics we can conceive of, we can look at the proportion or percentage of antibiotic orders are adherent to pathway recommendations. So just doing over a 1-month period of time, how many actually use one of the recommended agents as opposed to ones that you remove from the recommendations. How many antibiotic orders actually had indication for UTI, especially if you're trying to use more indication-specific orders. And then, like I said, days of therapy for specific antibiotics. So you would hope that once you've implemented this change in your recommendations for antibiotics for UTIs, you would see a decrease in the use of those antibiotics that are not recommended, such as fluoroquinolones. So your days of therapy for ciprofloxacin or levofloxacin should theoretically decrease. And again, we standardize that by your patient census in case that fluctuates between before and after your implementation. But ideally, you'd want to see a decrease in the days of therapy per resident days with the implementation of these new treatment recommendations. Other examples from the CDC, they say, process metrics, if going over months of data is not feasible at a time, you can also do something called a point prevalence examination. So you can look at 1 day or 1 week and just kind of look at how many residents are receiving antibiotics, how many courses have an appropriate indication, is the documentation for the order complete. If it's empiric, is that empiric antibiotic selection in agreement with your guidelines and pathway and antibiogram data? So you can do that over a 1 week period or a 1 day period, 1 day period to do more of a point prevalence type of examination. Thinking about outcome metrics, they're more difficult to assess and harder to show change. You usually need to have more patient data to show a change. For instance, C. difficile infection hopefully doesn't happen that often. So to show a meaningful change in the rate of C. difficile infection, you probably need to have a lot of data. Also, outcome metrics tend to have a bit more of a clinical component to them to assess whether or not it was truly a C. difficile infection versus just colonization. The other example we looked at was antibiotic adverse events. That does require a bit more actual clinical review of the patient to collect that information. So outcome metrics tend to be more difficult to actually assess. But if you want to look at an outcome metric, C. difficile infection would be one that might be important to you. And the way you would do that is you just look at general incidence, right? So incidence is basically the number of new cases of laboratory confirmed C. difficile infection over the number of residents over that time period. So incidence is number of new cases over the population at risk over that given time period. And you can just look at the incidence before and the incidence after implementing this new change. But saying that sounds easy, it might actually be you need to collect data for the year before and the year after that change to really show any significant difference. So instead of doing a day prevalence survey like we talked about with process metrics, we'd have to collect months of data to show a difference. Other outcome metrics, so we talked about looking at incidence of CDI. Other outcome metrics you can look at other adverse antibiotic events and those being treated for UTIs. Again, we eliminated fluoroquinolones as a recommendation. Fluoroquinolones, obviously a high-risk agent for C. difficile infection, but also tend to have a lot of adverse events associated with their use. So you might see a decrease in the reported incidence of antibiotic-related adverse events after implementation of this policy. And then you can also look at the proportion resistant to your empiric antibiotic therapy choices. Theoretically, if providers are following your new pathway recommendations, you should see less proportion of patients on therapy that's empiric that ends up being inappropriate because of resistance, because you've tried to decrease that risk through eliminating your antimicrobial agent options that had the highest risk of resistance to begin with. So those are some of the outcome metrics you can consider looking at with your implementation of your new pathway. I would say this would take more than a day, a week, or a month of data to collect. It would probably be at least a year of data to show a true difference, because again, these don't happen that often, so to show a difference in something with a small incidence and a small effect size requires a lot of data. And then, like I mentioned, antibiotic resistance is one of the harder things to actually track. Luckily, with the antibiogram, that tends to make it a little bit easier because you're already collecting that information on a regular basis and updating it on a regular basis. Annual antibiograms do allow you to track resistance of certain bug-drug combinations that are clinically meaningful and something that is required by CMS to actually track. So you can look at your methicillin-resistant Staph aureus, you can look at your carbapenem-resistant Enterobacteriaceae, and you can look at your rates of vancomycin-resistant enterococci. So you can kind of track those with each update of your antibiogram and see whether or not your rates are going up or going down, because you just have to look at your antibiogram, look at Staph aureus, look at oxacillin, and see the percentage of Staph aureus that are susceptible or resistant to oxacillin, and you can kind of track that with each new antibiogram. So again, it takes a lot of time because the antibiograms, again, annually, so this takes years to do, but the antibiogram does help you actually look at those trends. There's not a lot of published data actually out there in terms of how to integrate antibiogram information and then measure whether or not it was successful. In fact, this paper from Maryland was one of the only ones I actually found that tried to do that. It was the paper from Infection Control and Hospital Epidemiology from several years back about using antibiograms to improve antibiotic prescribing in long-term care facilities. And it was focused on helping to guide initial empiric therapy recommendations. Basically, this study was done locally at 3 Maryland long-term care facilities. They developed and distributed antibiograms at these sites. In one of the sites, a 118-bed facility, they also did an in-depth review of antibiotic orders for 6 months before and 6 months after to determine appropriateness of the antibiotic orders. And they said appropriate empiric antibiotic therapy was defined as an empiric antibiotic choice that sufficiently covered the infecting organism, considering antibiotic susceptibilities once they were available. So they looked at the orders, like I said, 6 months before and 6 months after they provided these antibiograms at the facility. They ended up evaluating almost 200 antibiotic orders. 85% of the orders they evaluated ended up being empiric therapy. And they found the appropriateness of those antibiotics increased from 32% to 45%. So though not statistically significant, arguably a clinically meaningful change in appropriateness of antibiotic prescribing. What they did find, what's outlined in some of the tables in their paper, is that the majority of antibiotic orders before and after the antibiogram became available to providers were still for fluoroquinolones, which was interesting because the antibiogram that they distributed actually showed their susceptibility rates to fluoroquinolones were actually only around 40%. So a lot of the inappropriate prescribing was still kind of around fluoroquinolone use. But they did show a slight, modest improvement in empiric antimicrobial use. That's really the only published example I have of this, but it is possible to show a change in prescribing by using an antibiogram by looking at your process and outcome metrics. So this is just the slide for continuing education credits. Again, following the webinar, an activity evaluation will be emailed to you. For CE, you must complete the activity evaluation. Just a reminder that faculty office hours will be held Wednesday, February 20th from 1 to 2 p.m. It's online. You can ask us questions about antibiograms, or in particular, if you have an antibiogram already set up and you're trying to figure out how do I actually measure whether or not we're using it appropriately, looking at these process and outcome metrics. We'll try and help answer questions you might have, so please feel free to come with lots of questions for us. And that concludes my side of this webinar. I'm not seeing a lot of questions in the chat box, but hopefully there's some questions online. Everyone is currently muted, but you can unmute yourself to ask your question. And if you have a question that you just want to type in the chat box, you can still do that, or you can unmute yourself. But I'll take questions about the material at this time. So Edna, I'm just going to read the group chat. I have a question from the group chat that I'm going to go ahead and read. Do you have any tips about specific footnotes and reporting ESBL MDR rates on the antibiogram? Is it okay? Is it okay to integrate specific therapeutic recommendations, for example, cost or preferred alternatives to costly antibiotics? I think those are two different questions. The first one, have any tips about specific footnotes regarding ESBLs and MDRs? So it depends on the type of MDR. For MRSA, you just look at your rates of oxacillin. For certain things like ESBLs, you'd have to look at your rates of, like, say, you look at your rates of third-generation cephalosporin resistance and use that as a surrogate for your ESBLs. So you don't know that it's technically a genotypic thing, but phenotypically, if it's resistant to third-generation cephalosporins, you'd assume it's an ESBL. You can put a note in your antibiogram saying that. What we end up doing, again, it's different for inpatient and outpatient. We have enough isolates that we can actually look at just our MDRs and do an antibiogram for that. Given smaller sample sizes, the thing that I would do is not so much you can make a note of it in the antibiogram, but also in your individual patient reports, highlight that if it has a phenotypic resistance, to go ahead and assume that it's going to have an ESBL present. I think that's what the question is asking. And is it okay to integrate specific therapeutic recommendations, cost or preferred alternatives to costly antibiotics? If the therapeutic alternatives are still appropriate for the infection, then yes, it's like, again, I'm focusing on gram-positives here, but if you have an MRSA infection, you're going to want to gear people towards using vancomycin over daptomycin because of cost. They're both efficacious for the infection, it's just you're also considering cost. So yes, it's perfectly okay to do that. I have another question on the group chat. Does anyone have a question from the phones that I could take? Okay, not hearing any. I'll keep going on the group chat. How important is it to include the number of isolates for each pathogen on the antibiogram? And what do you think about including pathogens with fewer than 30? So it's important to list the number. You can include less than 30. You just need to kind of give it that little asterisk that this is less than 30 isolates. So it's not recommended by our National Standards, Clinical Laboratory Standards Institute to make recommendations, but sometimes you have to. We run into that too, where sometimes you have less than 30 isolates, but you want to include that information for prosperity's sake. As long as you make the end user of that antibiogram aware that you have less than 30 isolates and the potential implications of that in terms of generalizability, then it is definitely still okay to include less than 30. But in the general buildup of the antibiogram, it's important to still include the number of isolates you have for each, so that the reader or end user of the antibiogram is aware that, hey, for Acinetobacter, we only have 10, but for E. coli, we have 147. That's something that, as an end user, I would want to know. Someone did ask about elaborating on the MIC in the culture and sensitivity report. I am going to ask that you elaborate on your question a bit more. I'm not 100% sure what you want me to elaborate on, but I can definitely do it. I'm just not sure which part. So if you can add a bit more to your question, I'll come back to it. The next question I have here is expand on use of individual facility antibiograms versus regional, especially when isolate numbers are small, much less than 30. So regional antibiograms are something that has been published on a little bit. You can find a few papers on it. Not so much in long-term care. Again, publications that are long-term care specific are limited, but there are some in acute care as well. where if you have a bunch of hospitals that are in a geographically similar area, they're serving similar patient populations, they might even be serving some of the same patients in terms of them going back and forth between facilities, then they might try and combine susceptibility information. This becomes challenging if you're using more than one microlab. If you're all using the same microlab, theoretically you should be able to do that easier than if you're using multiple. But you can use that information from that group of facilities to develop a larger antibiogram that will then be used at all of the facilities included in that antibiogram. And that is a way that you can kind of overcome that limit of 30 isolates. It is, for a regional antibiogram, probably for long-term care, it's good to consider having a regional antibiogram and working with your nearby long-term care facilities to develop that, as opposed to just taking the antibiogram from the nearby acute care hospital, such as Maryland, and trying to apply that. Having a regional antibiogram, although not 100% specific to your patient population, will still be able to be applicable to your patient population. Okay, what are your thoughts about the necessity of making a more granulated form of the antibiogram available, for instance, a breakdown of unit or specimen source? We're concerned about presenting too much information at once at our end users. So I think that's an interesting question, because in acute care, we do have that concern. Sometimes we'll have unit-specific antibiograms or source-specific antibiograms. Urinary antibiograms kind of make sense, but again, it goes back to, do you have enough samples to actually do that? If you have enough samples to actually do that, then the question becomes, should you do that? And it kind of depends on your institution. And like you said, you don't want to present too much information to the end users, but sometimes some of that information might be useful. In particular, a urinary antibiogram could be useful because urinary tract infections are one of the most common causes of infection in long-term care. So if you have proper education around the use of those more granular antibiograms, then I think there's still benefit in them. But for unit-specific ones, it kind of really depends on your site and how much you feel like they would be of use, and if you can actually feasibly do them with your sample size of isolates. So for the MIC question, it was for MIC, how can we use MIC to guide antibiotic use? Well, Dr. Johnson kind of talked about this at the summit, and she might talk about this more next month as well, but the minimum inhibitory concentration, as it gets referenced to our clinical breakpoints, the MIC helps you determine whether or not the organism is sensitive, intermediate, or resistant, yes, but the MIC also kind of helps tell you whether or not you're going to achieve your pharmacokinetic, pharmacodynamic targets. So the minimum inhibitory concentration, that's the concentration at which bacterial growth is limited when you do a series of doubling concentrations. So when you see your MICs, they go from like 0.25 to 5 to 1 to 2. That's the concentration at which the growth of the bacteria has been visibly inhibited. By having MICs, such as the example I showed you, you can't really compare between antibiotic classes. You can't say, oh, well, ceftriaxone had a lower MIC than vancomycin, so I'm going to use ceftriaxone. It doesn't work between antibiotic groups, but allows you within antibiotic groups to make a decision. So beyond susceptible, intermediate, resistant, if an MIC is, say, 4 for meropenem compared to 0.25 for meropenem, we know that the gram-negative, in this case, we know that the organism that has the MIC of 0.25 is more susceptible, where if we have an organism with an MIC of 4, we might have to use more aggressive dosing. So it gets kind of into the dosing of the agents as well. So the breakpoints are the first step to just kind of look at, will this even work at our standard antimicrobial doses? The MICs then get into whether or not we need to adjust our doses. I hope that kind of answers the question. Is it okay if the facility, as an antibiogram diagram incorporated in the antibiotic stewardship program, can that be sufficient for facility physicians to follow, or there has to be a separate policy for antibiograms? I think think it depends on hospital administration, but I think there usually has to be some policy in terms of how the antibiograms are prepared and how they are maintained. But otherwise, having an antibiogram incorporated into the stewardship program is a good way to have it readily available to physicians. I don't know if there needs to be a separate policy beyond making sure that you have a policy that you can have an antibiogram and have a policy that should be updated and by whom. But beyond that, I think that having it available through stewardship is a good way to help distribute it. Okay, so should we be concerned that many of the UTI cultures are positive but are not actually pathogenic, i.e. symptomatic? Is it acceptable to include these cultures in the creation of the antibiogram? Well, that's a great question. So one of the things that Dr. Leaker, she talked about proper diagnosis and treatment of UTIs at the summit. She's going to come back, I believe it's in May, and talk about something called diagnostic stewardship. And that's a big problem we have, especially with the UTIs, where we are triggered to get a culture, the culture's positive, there's no symptoms, are they truly infected? Theoretically, those ones that are positive will still be included even if they're not symptomatic because they were drawn as a diagnostic sample. Whether or not they should be included is a great question. I think that would be something that Dr. Johnson or Dr. Leakey can speak to during their presentations a bit more, but if it's drawn for the purposes of diagnosis and treatment, it will be included in the antibiogram. But the idea that Dr. Leakey is going to talk about is how do we decrease that inappropriate testing. So I talk about antibiotic stewardship a lot. What Dr. Leakey does in terms of infection prevention is something called diagnostic stewardship. So how do we limit those cultures from even being ordered in the first place? So hopefully by limiting those inappropriate cultures, we decrease the inappropriate positive results we get that can then skew our creation of our antibiogram. That's a great question. So I think I've got all of them.
Are there any other questions for Dr. Claeys this morning? If not, I personally want to thank you, Kim. That was outstanding. And thank you so much for reviewing this rather complex topic in a very clear and detailed fashion. I see one more question has come in on the chat. Would you like to take it? And then we'll close out the session.
Yeah, I can take it. This kind of goes back to diagnostics, but I think the question, it says if a patient is treated for UTI within the same month, like say January, and was treated maybe 3 times, and they were asymptomatic and the family keeps requesting it and it's still positive, do we count that 1 or 3 times? So I didn't go into too much detail about how the antibiogram is being made. Dr. Johnson's going to talk about that more. You take the first sample during that time period and only include that one. So if they keep getting positive cultures, only the first one of the time period for the antibiogram will be included. And then that sounds like another question that would be really good to ask Dr. Leakey, because you're having a family keep requesting antibiotics, and how do you deal with that kind of situation where they're not even symptomatic, but you're feeling pressured to prescribe something? That's a whole different question in and of itself. That's challenging, something that's kind of more unique to long-term care than acute care as well as a challenge. The session with Dr. Johnson's next March. It's going to be the next webinar.
Kim, did you have anything else you wanted to add to the presentation this morning?
No, I just want to thank everyone for attending today, and thank you for the opportunity to present. We have our office hours, I can go back to the slide, on the 20th. If you've got questions about process and outcome metrics, please feel free to bring them and I'll try my best to answer them.
And this is Barbara. We'll sign off. Please remember when you get your email with your continuing education evaluation to complete it in order to achieve CE. And the up and coming webinars, I see a note from Dr. Brandt, are posted on the LAMI site So you can take a look in advance, refresh your calendar for the dates, look at what the topics and who the speakers are going to be, and we'll be excitedly waiting for the next time we can all gather to review this important information. Thank you for attending. Everyone have a wonderful day, and this ends the program.